This is a patient with pelvic mass observed, like seen on ultrasound. This is a MRI from the outside facility. So those are your T2s, and then here's a fat set T2. These are your reproductive organs down there, and the mass is right there.
So it looks
and then
separate from
ahead.
the ovaries, and like there's no connection to the uterus, right?
Correct. Yes. So the ovaries are here.
Yeah.
The other one's here and separate. And the uterus, correct, it's separate. So the uterus is here. You can see there's a nice fat plane between the mass and the uterus.
And then wait, I think I see there's some kind of like stalk with something at the superior margin of the mass, I feel like. Right there. Or wait, there's some
Here? No, it's just vessels, like these little flavoids.
No, at the superior margin of the
Oh,
mass.
superior, sorry,
Yeah, like
superior.
there's vessels going into it.
So
There's
I
no
see
small bowel loop
bowel.
that it's connected to.
Here, let me see if this sees it better. So is this what you're talking about? This
Yeah, I
dark
guess I
thing?
was thinking of that thing, but I guess maybe that's just a big vascular
Yeah,
stalk.
I think so, because there's a flow void there. And I can pull up, do we have contrast? We do. We don't have coronal, but the outside did acquire axial. So yeah, that's probably the vascular supply to that mass right there.
Okay, but there are some small bowel loops that are connected, or like that seem to come on the left side of the mass.
Left
Patient left.
side of the mass.
I guess just to cut to the chase, like you always think about GIST when you see big masses. Although this looks weird for a GIST, it's usually GISTs are like centrally necrotic, not with these cystic spaces peripherally.
Oh, I have CT, so let me show you CT. I think CT is kind of helpful to clarify the anatomy. So the bowel is here, and it's separate from the bowel.
Although
I
it's
mean,
touching some bowel loops, so like if it
it's
was,
touching it, but it doesn't. I mean, go ahead.
well, I was just gonna say if it looked more like a GIST morphologically, then
Yeah.
touching small bowel loops could mean that it could arise from it. But I still think it looks weird for a GIST, so I'm thinking something along like a mesenchymal tumor.
Good. Good. So this was resected, and it is a solitary fibrous tumor.
Oh, nice.
Yeah, and so here's the radiopedia. Sorry, I should have pulled the radiographics, but this is the first thing that pulled up on Google. So solitary fibrous tumor, they can be anywhere, actually. Anyways, the imaging appearance of it is, I always thought that they were just solid enhancing, and this case I was kind of surprised because it looked kind of cystic solid, right? Right there. And when we saw the T2, it's kind of cystic solid looking. So
Yeah,
I
I'm
was kind
kind of
of
kicking
curious.
myself in retrospect because I have seen some with like a bunch of cysts in them.
Cystic, yeah. So yeah, it is a mesenchymal tumor, and the imaging features it is solid, usually solid, but sometimes you can get cystic changes, like if there's necrosis or hemorrhagic changes. So, and I mean, I don't think this is hemorrhagic, because its T1 is not high, so I don't think this is hemorrhage, but just know that you can have solid cystic appearance. Here is, it looks like this is like post. Where's the pre? So we don't have all the sequence here. This is a pre, but it's not really a T1. Sorry, they didn't get fast at pre T1s, which is weird. Anyways, so the solitary fibrous tumor, like I said, it's solid, but it can have cystic look to it, and they can happen everywhere and anywhere. So.
I feel like in residency, people always teach about it arising from the pleura and causing like low hypoglycemia because it produces insulin-like factors. But apparently it's also really just as common in the retroperitoneum. And then, like you said, it can actually happen anywhere. So mesentery, soft tissue.
Liver. We've seen liver. Solitary.
Yep.
Like Victoria showed a case of a liver fibrous tumor. Solitary fibrous tumor.
Although often it's like from the ligaments of the liver, like the falciform ligament. So like it looks like it's liver, but
Oh.
it's actually like from some of the external areas.
Oh, gotcha. Okay, that makes sense because that was really bizarro, that case from the liver. Here, and then they can have calcification. So here's an example from Radiopedia that has, you know, another picture or another image. I think this, I don't know if this one had calcification or not. Oh, no, this one doesn't, but it has central necrosis.
Okay, so for the residents who are on, one, what's the name of the syndrome you get if you get hypoglycemia from your solitary fibrous tumor?
I don't remember. It's like Dober-Hurix or something like that.
What'd you say?
Like, isn't it two names? I think it's like Doman Hertz or I don't remember. I think it's
Yeah,
something.
it's Doge Potter syndrome.
Oh, okay. I was relatively close.
Yeah, yeah. So you would have definitely recognized it on a multiple choice board exam. And then the other question I was going to ask is, so are these benign or malignant?
Benign. I would say benign.
So they are on a spectrum, and so they have malignant potential. And I think about 20% end up being malignant. And so, and the malignancy, like the Mets can happen up to 10 years later. So even if you had a benign one that was resected, you have to keep following them up for a while. And we've definitely had some that have metastasized. So yeah, cool. Okay. I have a case. Hold on. I'm going to pause. Okay. So trying to take off the, okay. This patient had had a liver transplant. You can see that there are 2 IVCs here. So this is the piggyback anastomosis of the liver transplant and some surgical clips, which are always a clue that you're dealing with a liver transplant. And post-liver transplant, they had a hematocrit drop. And you can see here that there's a big hematoma here. It's kind of a nice look for a hematoma. It's got like a heterogeneous but hyperdense areas. But what do you guys think about the pancreas?
Very calcified or enhanced. It looks like it's enhanced. It's got a very odd enhancement pattern.
Okay, an odd enhancement pattern. Somebody said calcifications. Good. So there's some like all these densities here, right?
Is there some sort of fistula between the arteries and the duct or something?
Oh, good. That's a great thought. That is not what is happening. And actually, I'll show you. The duct is back here. And so when I initially looked at this, I was like, okay, stippled calcifications in the pancreas. I didn't look that closely. I was just kind of like, okay, there's calcifications in pancreas. They likely had chronic pancreatitis. They also have a liver transplant. So maybe this is all connected, related to alcohol. Don't know. But if you look a little closer, I'll just tell you, these were not calcifications and it was not a fistula with the artery. But it does look like there is density in like a, a linear structure going into these other linear structures and even
Did they inject contrast?
Yes. Yeah. So what I didn't know is that they had actually embolized the splenic artery and all of the pancreatic branches because they were bleeding into this hematoma. So if you go back, I'll go back 2 days.
Wait, is that going to take out the pancreas?
Yeah. So I had never seen this before. This is exactly the point of showing this case. I've never seen them embolize the pancreas. But
Wait, was it intentional to embolize the pancreas?
Yeah. They intentionally did it because the patient was basically having active bleeding right here.
Extravasating. Yeah.
Yeah. So, okay.
Sanguinating,
So just go back. So we're now rewinding 2 days. We have very active hemorrhage with a hematocrit level, which is like usually a sign of active hemorrhage with, 2 different levels here. And then we can see the pancreas, the pancreatic duct, but then one of the branches of the splenic artery was here actively extravasating. So they went in emergently and then embolized the splenic artery as well as branches of this the pancreas. So generally we don't like to do that. That will cause pancreatitis, that will kill off your pancreas. You could become, insulin dependent. But because it was, a very acute case, that's what they had to do. So I just wanted to show this because I had never actually seen this before. So this is all like embolic material in the pancreas, and then actually even a branch went, of the splenic artery. This was one of the branches that they embolized, went to the spleen. So we ended up with a splenic infarct over here. You only need 25% of your pancreas to make enough insulin to, to not become insulin dependent. So, the head here is still okay. So that was another thing I wanted to share was just the blood supply of the pancreas. So just to review, the body and tail are supplied by the splenic artery and branches of the splenic artery that are called like the pancreatic artery. But then the head is supplied by this rich vascular supply that comes off of both the GDA as well as the SMA. And it forms this pancreatico-duodenal arcade. There's multiple names. There's like the anterior superior branch, anterior inferior branch, posterior inferior, just kind of like multiple branches that form this arcade. And this is the arcade that gets activated. Like, for example, if you have median arcuate ligament syndrome and you don't have enough flow to your hepatic artery, your SMA can come through these pancreatic arteries in the head and retrograde fill your GDA and then your hepatic artery. So just to review, pancreatic blood supply, the head is supplied by these guys, by the GDA and SMA in this pancreatico-duodenal arcade. And then the body and tail are supplied by the splenic artery and the pancreatic branches. This is the reason if you have like a cancer in your pancreatic tail, you would resect your whole pancreas, but you also resect the splenic artery, and therefore you have to do a splenectomy as well, because you're going to be missing, that vessel. So yeah, just wanted to show that.
That was great. That makes sense now. Like, why do they take the spleen every time they do a distal pancreatectomy?
Yeah, I didn't understand that at first because then you have to like be on all these antibiotics and stuff. But yes, because if it's an oncologic resection, like say there's a pancreatic adeno here, they cannot separate that. They have to do like a wide margin oncologic resection, and therefore they have to take the splenic artery and vein, so they have to take the spleen. But if it's for like a benign cause, or like for example, if there's like a small neuroendocrine tumor and they're enucleating it, or it's some kind of benign cause, then they don't have to take the spleen. Only if it's a true oncologic resection.
So Aarti mentioned the piggyback technique that was done in liver transplant. For the residents, in case you're not familiar with the piggyback technique, it simplifies the vascular anastomosis so that now you only have one vascular anastomosis to do instead of more than one. So with the piggyback technique, what they do is they take the donor IVC. So this is the donor liver, the donor IVC, and then they take the suprahepatic IVC, and then they anastomose that to the recipient hepatic vein, so that it makes the surgery easier because the surgeons only have one anastomosis to do. So that's an example, like that's a rationale for a piggyback technique.
And so, yeah, the hepatic veins have already joined, but you can see actually in that picture that you just showed, Nelly, there's like this little blind end to the native. Yeah. So there is risk for thrombus in that little blind end, although usually the flow is going so much forward that, it's not a major issue, but there is that.
And it's common to see thrombus here. So when you see a little clot posteriorly, that's a clue that they did a piggyback approach, because this one almost always clots because there's no laminar flow going through it because it's a blind ending. This end is ligated, but it doesn't interfere with the graft function normally. This is a great case for the resident. A patient came in with GI bleed. So we did a GI bleed protocol. So here is actually, maybe I could do side by side. Here. So here's your arterial and then your venous. Let me give you the axials.
Residents, what do you think? Do you guys see anything?
There's a little blip in the central, I guess like right paramedian valve that you can see better on the venous phase that's sort of blinding.
Sorry, where?
The central, oh, I said right. I'm sorry, the left side. Of the
Okay,
patient.
good. I was
Like certainly it was helpful, obviously.
like here, you mean?
Yes.
Good. And where is that? What structure is that in? Okay, let me give you the, let me give it, I think the coronal's easier sometimes.
That transverse.
It's the transverse colon. Okay, so this is sigmoid. It's a sigmoid. It's this thing here.
Oh, it's redundant.
Sorry, I don't want to like. Yep, it's a redundant sigmoid. So it comes up and then loops back and then goes up, which is not uncommon. So yeah, so and it's coming from what structure? In the sigmoid.
Little diverticular.
Yeah. So this is a diverticular bleed. So yeah, we do biphasic arterial venous. We also do dual energy, but this one was not done with dual energy.
Wait, Nelly, when you say
yes.
biphasic, we do triphasic because we want the non-con first to make
Oh,
sure.
I'm sorry, triphasic. My bad.
Okay,
No. Yes, this is like one of the 5 indications for a non-con, right? I mean, we rarely do non-con for abdomen and pelvis, but GI bleed is one of them. So
yes, because if you have contrast in your colon for whatever reason, it like very much limits your exam. Did you guys
100%.
embolize that?
But now we no, it resolved on its own. But now we can do virtual non-con.
Yeah, we don't have dual energy on all of our scanners, only a few.
There's
okay. So patient has history of multiple myeloma.
plasmacytoma.
I was gonna say, but in Arkansas they call it EMD, extramedullary.
EMD.
Oh, okay.
So look at the signal intensity.
Very blobby, T2 heterogeneous, very homogeneous, delayed enhancement, progressive enhancement.
T2 signal in particular is
kind of dark.
Evil.
Yes, exactly. And this is the arterial phase here. And this is the most delayed phase we have. So EMD, that's what we thought. But since you guys showed a solitary fibrous tumor, Kedar found this case, especially for you. This is a solitary fibrous tumor. It was biopsied.
And that's separate from the ligament.
And I always get tricked by these. But you know what? This actually shows you how the T2 can look so variable, right? Nelly, like yours had those cystic spaces. This one's dark. Yeah. I've had ones that are bright. Like, I feel like they just do so many different things. But afterwards, like now I'm not surprised. Like,
yeah, there is no winning. Anyway, I may have a very quick case. Just one image. I mean, I don't know how much chest you guys do, but
0.
Just a lung basis.
But I do see like scarring in both upper lobes, pulling hyla up.
Histiocytosis.
So what is the differential diagnosis of upper lobe scarring and volume loss?
The residents need to help us here. She's a TB.
Yeah, TB, absolutely. Fungal TB, sarcoid can do that. Pneumoconiosis can do that. Chronic.
Taking me back to my chest rotation days as a resident.
Yeah, but the clue is right there in the radiograph of a rare entity which can do that.
There's a cancer with the fracture in the left proximal. Arm. Yes.
Patient has a broken arm, deformed appearing humerus. Yes.
Pathologic fracture. We still got it, Aarti.
No, he didn't say we got it.
No.
Oh, there's nodules. Oh, neurofibromatosis.
Yes. Yeah, this was a case of neurofibromatosis. Bad fibrosis.
Wait, what does that do to the lungs? I've never heard of that.
It causes this. So there are 2 rare conditions which can cause similar type of fibrosis, upper lobe predominant fibrosis.
Can you double?
So one is neurofibromatosis, other is Angst-Pont.
Oh, ankylosing spondylitis. He does MSK, Nelly, so he's using like even like shortcuts.
Yeah, I'm like, oh, this is like way beyond my abdominal.
Wow. Cool.
Okay. All right. Yeah.
Okay. This is my next case. So residents, what do you guys think? I'll just tell you this. There's a mass and it's coming from the pancreas. The claw is kind of right there. I'll show you an MRI in a minute, but just based on the CT, what are you guys thinking about this? And the patient is like a 30-year-old female.
Yeah.
Speak up, please.
SBT.
SPT, solid pseudopapillary tumor. Good.
Ben, wait.
Yeah, we call them SPEN, solid pseudopapillary neoplasm. But some people call them SPTs, so that's fine. Okay, good thoughts. So solid and cystic mass coming from the pancreatic tail, youngish female. Okay, now I'm going to show you the MR. Okay, here it is on the MR. It's from the tail. It's got cystic, solid parts. This is the pre-contrast. There's an important teaching point on this pre-contrast. This is the arterial phase. And this is the delayed phase. So do you still think it's a SPEN? Did any of you attend my ARP lecture on this topic? On cystic pancreatic lesions?
None of us have gone to ARP yet.
Okay, you're excused. But okay, so I'll just tell you in the end, this was not a SPEN. And when this was presented to me, I said, I don't think this is a SPEN. Oh, by the way, this is the diffusion. So the solid part does restrict. You can see it's got that big rind of bright diffusion and dark on ADC. But one clue here, and it kind of doesn't matter. This is a surgical lesion. It's a cystic and solid mass. It's arising from the pancreas with this claw. It has to come out, especially in a younger patient, but yes. Some other things that people brought up were an acinar cell tumor. Those are usually in older males and can cause hyperlipemia. A necrotic adeno wouldn't usually look like this, not well-defined borders. And then something I brought up, which is a neuroendocrine tumor, and that's actually what this was. So this was a cystic neuroendocrine tumor, very common lesions of the pancreas. But one thing I want to point out is that SPEN tumors, when they're solid, they have these pseudopapillae that are all packed together. And as they grow larger, they outgrow their vascular supply and they hemorrhage into the center of the lesion. So even though on CT it might look cystic and solid, it's actually hemorrhagic and solid. So one clue that this is not a SPEN is that there is no T1 hyperintense hemorrhage here. And then the other clue is that the solid parts don't really look like pseudopapillae, like they don't look like frondy kind of things, although SPENs can be variable. So I think it's totally reasonable to put SPEN in the differential, but because there wasn't hemorrhage here, we also put neuroendocrine tumor. Less likely to be something like an acinar cell because it's not an older patient, and very unlikely to be a necrotic adeno. And this turned out to be a neuroendocrine tumor. And just a few points about cystic neuroendocrine tumors. They're about 15 to 20% of neuroendocrine tumors can be cystic, and they have a better prognosis. In general, neuroendocrine tumors tend to be hyper-enhancing, but these cystic ones have these cystic spaces. They're not necessarily from necrosis, is not a sign of aggressiveness or, outgrowing its vascular supply. It's just basically they can secrete hormones into these areas, like all the different things that neuroendocrine tumors secrete, and create these like cystic spaces. So yeah, this was just a low-grade cystic neuroendocrine tumor with no lymphovascular invasion, and no lymph node involvement. And they did a distal pancreatectomy and splenectomy for this one.
Okay, this is a patient with this finding in the kidney. Patient is in the 20s, early 20s. What are we thinking? So this is the CTU. There's a left lower pole renal mass, and it's causing probably a little bit of obstructive hydro.
It looks really atypical for a renal cell.
Okay.
It has like vessels. Doesn't
I'll
have
give you
any true
Go ahead.
fat, right?
There's no fat, correct. On the in and post phase imaging, there's no fat. So where is my in and post phase? Okay, well, in the meantime, I'll give you diffusion.
So lots
Here's
of
your DW.
restriction.
Yep, yep. Yeah, it was the T2 is heterogeneously T2 hyper. And then here is your pre, maybe a little bit of hemorrhage within the tumor. Here's your subtraction, or sorry, arterial, and the subtractions here. There is low level enhancement right there.
Okay, I'm just going to go through
So
the thought process for the residents. So
good.
normally clear cells tend to have central necrosis, arterial enhancement, and washout.
Yep.
So that doesn't look like this. Papillaries can be T2 dark, hypoenhancing, or hemorrhagic masses with like a papillary frond with hemorrhage. Doesn't look like that. Chromophobe or oncocytic neoplasms can have like a central scar. They tend to be more kind of bland. So I was thinking about that with this bland appearance, but I don't see the central scar. This has more like a whorled appearance. Some unusual tumors you can get in the kidney are like neuroendocrine, leiomyomas. Leiomyomas are usually darker, T2 darker. Obviously an AML, but you said it didn't have fat.
Yeah, there's no macroscopic or microscopic fat. Here's our in and post phase imaging, and there's no intralesional fat. And then
Although it could
there's
always be a
no
lipid poor AML, but
lipid poor AML.
they don't
Why is this
necessarily
not
have
a good?
microscopic fat, but
And
yeah.
they're T2 hypointense. This one is
Yes, yeah.
T2 heterogeneous. So it's
And
not
it's
a
got
good
that
look
foam.
for, and they have enhancement like clear cell renal cell carcinoma. This one is hypoenhancing. That's
It
another
doesn't look
reason
great
why
for
lipid
lymphoma
poor.
either, and I don't see other lymph nodes.
Agree. Yes, to all of the above.
Okay,
Patient is
now someone
20,
else
early
needs to
20s.
diagnose this. Wait. Is there something? No. There's hereditary
Early 20s.
Hmm.
Would it be medullary?
Medullary what?
Renal cell?
Like,
Like
oh,
if
like in sickle cell?
yeah.
No. I mean, yes, it can be, sure. Does it, I don't know what do medullary, it's like, it's so rare.
They're usually
don't
really
know.
aggressive. This looks more well-defined to me. What about like a messed?
Messed, but it's not very cystic solid looking, no?
Yeah.
This is solid. Okay.
Melina,
So
save
anyways,
us. Tarun, save us.
Sorry, not to know.
Okay, Nelly.
this was a
Oh,
Wilm's tumor is the most common patient is early 20s, very, very early 20s. I don't know if that qualifies, if the patient still qualifies under pediatric, but I think the age definitely, all the other ones that you mentioned are we usually associate with older people. In young people, I think it's a different set of differential. And Wilm's tumor, I think, so Wilm's tumor is most pediatric renal tumor, and actually a very common pediatric cancer overall. So let me see. They're usually
and those
very young
images
people.
on the right there look like
The
your
right.
case, actually.
On the right, this one?
Yeah,
these
like,
things?
yeah.
Yeah, let's check it out. I didn't check out the. Oh yeah, that looks like my case, right? It's hypoenhancing. Totally, absolutely. Yeah, let's look at that. Let's see if they have any MRs. Here's another one. This is CT. I don't see any MRs, but There's a coronal post-con. Yeah, it's hypoenhancing, washout. They're big and they're very well circumscribed and kind of encapsulated looking. Causes hydro. Yeah, this could, yeah, absolutely agree. So anyways, this was a case of Wilm's tumor.
And in adults, is there like, what's the prognosis?
Oh, let me go back to the Radiopedia article. That was the first thing on my Google search. So prognosis, I think they're pretty good, but let's double check. Prognosis. They're treated with nephrectomy and chemo. Radiotherapy has a limited role. Cure is possible in over 90% of the cases. Recurrence can be seen in tumor bed. So they do very well. Curative in 90% of the cases.
Nice. Okay, this patient is youngish and has a history of cervical cancer. So first of all, residents, what type of cervical cancer is, like, can you get? What are the types of cervical cancer?
Serous mucinous.
No. So they're usually squamous or adenocarcinoma. Squamous is more associated with HPV, which now we have a vaccine for, so it's like on the way down, but they can also get adenocarcinoma. And in this case, you can't see the cervical cancer well on the CT, but you can see that there's hydro. So we know that, you know, it's a pretty advanced cervical cancer. That hydro was causing malfunction of this kidney. And then this splenic process was new. What do you guys think? Do you think, would you call this a possible met from that cervical cancer? Would you call it something else? A year ago, there was nothing in the spleen.
How about the liver lesions?
Yeah, and the liver, great. So in the liver, we didn't know what was going on. It looked like perfusional abnormalities, wedge-shaped, peripheral. But anytime you have a malignancy, if you see new perfusional abnormalities, you should go to the apex of the perfusion abnormality and see if there's a metastatic lesion there that might be taking out the portal venule. And therefore, like, you know, there's some, in this case, this isn't a arterial buffer response. This is actually, you know, decreased perfusion. But let's just ignore the liver for now. Tarun, what would you say about the spleen? Would you say, like, I think it's a MET? Have you seen cervical cancer MET do this?
Yeah, I have not seen cancer met, cervical cancer met to spleen, but it can be, I guess.
Yeah, so we were really confused. And so I would say this is a differential case. We said, like, you know, if it's, I guess it could be a MET, but it could just be like an abscess. Okay, so time went on and the splenic process was getting bigger. And they went and aspirated this and it was pus. So it was infected. And
Wow.
so we're like, okay, it's pus, you know, done, abscess. But I will just want to point out, for example, here, you know, you want to look carefully, even though something looks like dominantly cystic, just always have, like, you know, be very vigilant. So here, oops, got it all marked up. But anyway, as you know, now looking closely, you can see that there's probably a solid component here that looks different than the spleen. There's some enhancing septations. So, you know, even if it comes back infected, that doesn't mean that it's not super infected. Anyway, time went on. We said it was like splenic abscess. It came, you know, it had this stuff growing out of it. And then eventually they came back. And this, I'll say this, all this stuff was not enhancing. So this was still like that part that, you know, we thought was originally the abscess. And then suddenly there was this large, new, evil gray T2, you know, intermediate component, like this large mass that showed up here. And I'll show you the post contrasts. I'll actually just jump to the subs. So most of this thing was still probably either necrotic tumor that's got super infected, no enhancing components here, but just look carefully. That nodular part that we saw previously basically busted out and grew into this large mass. They eventually biopsied this and resected it, and this was all squamous cell carcinoma. So
Wow.
yeah, it was a mystery case for us. Very unusual.
I'm sorry, can you show the diffusion again?
Yeah. And I will say another thing, on the final path, they resected the spleen, the distal pancreas, etc. And the final path said 19 centimeter squamous cell carcinoma. So
then the pus,
saying
it just got super infected, or like where did the pus come from?
Yeah, that's what we think. It was like necrotic tumor that got super infected.
Oh, gotcha. Okay.
So like even satisfaction of search can even happen after you aspirate. This is the diffusion. And
so the pus is not really restricting.
No. And actually, at this point, this was like a couple of months after they had aspirated it, and they've been on antibiotics. But I can
maybe sterile.
go back to let me go back to the original. Okay, this was earlier on. Still the central, it's not really restricting. Yeah.
Yeah. It's not a good look for abscess.
Yeah, now it's weird.
Maybe it's primarily more than
the peripheral part is restricting. That's
and there's more soft tissue component on the follow-up.
Yeah, and look at that big component there. But like,
yeah,
so this all, it's interesting. That all is restricting, but it's not at all enhancing.
Huh. It is interesting. Yeah. But cervical cancer is known to be hypoenhancing, right? Like
it's like not enhancing. So I don't know if like maybe that's
Venus?
the plus.
Can you go to Venus?
Yeah, but this is the sub from the Venus. I mean, I think the non-subs are a little confusing because there's a lot of. Yeah. See, there's
a little bit low level enhanced. Oh, wait, there's hyperdensity. I mean,
right. So this is the pre
signal.
So I just think the subs are better here, but this is the sub. So anyway, interesting case. We followed it for like months, and we thought it was an abscess. Like, first we were like, it could be a really aggressive met. Then we're like, okay, it could be an abscess because they aspirated it, and then turned out to be a big met. And then I wanted to point this out. So then they tested this for PD-L1, and it came back with high levels of PD-L1. And I just want to show you that this was from New England Journal in 2021, that a lot of cervical cancers actually express PD-L1. And so they can use pembrolizumab, which is a PD-L1 inhibitor, and with a significant survival benefit for metastatic cervical cancer. And I can't go into super detail here, but what I kind of understood is that tumors express the PD-L1. So when you give a PD-L1 inhibitor, it blocks the tumor and the tumor associated fibroblasts, and stops their proliferation. But yeah, so they're planning to give this patient pembro because this is now metastatic cervical cancer.